Hi, my name is Jerry Hesch. I'm a physical therapist and a manual therapist. I practice part-time in Henderson, Nevada. And I want to share some ideas on cuboid syndrome. Cuboid syndrome has been described for more than 25 years in the literature, but episodically. If you look back in the last 10 years, there's only a handful of articles that have been done on it. If you read those articles, you get the sense that there's a little bit of vagueness surrounding cuboid syndrome. Terms like hypermobility and hypomobility get thrown around a little bit without a clear explanation of specifically what structure is hypo or hypermobile, which direction is hypo or hypermobile, etc. The literature speaks of an acute event in which someone has pain in the region of the cuboid bone. Usually a traumatic injury, and what's nice about it is it responds beautifully to a manipulation, and usually these clients require only one treatment, occasionally two, and on a rare occasion maybe three treatments. Basically what's proposed is that the cuboid moves and gets stuck, and that the maneuver to move it back in place involves a thrust from underneath, which would push it vertically and also rotate it at the same time. What I suggest and what I believe is that most of the time a cuboid syndrome involves a sprain in which the cuboid rotates laterally. So if we're thinking of an anterior-posterior axis, then the cuboid whips out. That's also an inversion sprain. Okay, so instead of spraining the ankle here, as is most common, it's a little bit more forward. Perhaps they were plantar flexed a little bit and captured that portion of the midfoot. Anyway, my belief, based on palpation and spring testing, is that on the side of cuboid syndrome, the cuboid is more prominent. And so the mechanism for making it more prominent, if you look at how it rotates when it goes in a medial direction, this happens to be the right foot, you can see that it would not become significantly prominent on its lateral border, whereas if it rotates outward, it immediately becomes more prominent here. Okay? The other finding that you'll have is that when you capture the cuboid above and below, you'll notice that you cannot spring it inferiorly. I must say it's quite difficult to do a passive mobility assessment from underneath. There are simply too many dense connective tissues underneath for you to capture it with confidence, although I have tried many times. So I want to say that the treatment that is proposed in these articles and case studies that are successful is that they actually succeed not because they're treating it in the correct direction, but rather because what happens is they gap the joint. So the ligaments bring it back where it belongs. My technique, which I prefer, is to create space for the cuboid, which again is rotated outward, to create space by rotating the navicular, which is absolutely designed for rotation. Okay? And I bring the midfoot into medial rotation, and then I capture the cuboid, and then I rotate it into pronation, at the same time performing an inferior glide. Now it's helpful to be cognizant of the shape of the joint, okay, in the front where it articulates with the base of the fifth metatarsal and the base of the fourth metatarsal, and it also forms a joint with the lateral cuneiform, and it also forms a joint ever so slight, there might be a facet connecting the navicular. Okay, the biggest facet is going to be the calcaneus. This is a massive articulation with a very large bone, the largest bone in the foot and ankle complex, ignoring the tibia, of course. The largest structure is the calcaneus. Okay, so in this model that I took apart, which you really need to do, you need to take these models apart and put them back together to see how motion is linked. But this is the calcaneus, and this is the articulation that forms with the cuboid. So the point that I'm trying to make is that the calcaneus has a profound influence on position and mobility of the cuboid. I'm going to speak of a very simple cuboid syndrome, and then I'm going to build a model on a more complex one. So if someone has a chronic cuboid syndrome and the traditional approach isn't working, then I would suggest to you that there is a solution to that. Before I build that model, I'm just going to show you a picture of the foot here. Okay? And this is from an anatomy book called Human Anatomy. I don't see an author there. I like it because it's a very large view. This is the fifth toe, right? So this is the lateral border of the foot. And here you have the fibularis tendons, the fibularis brevis and longus underneath that. And the cuboid's going to be underneath there. All right? It's going to be right in this region. And I'm going to show you another view that shows the ligaments. So in this view, again, we're looking at the right foot. So here's the small toe, okay? This is the foot is adducted, okay? And at the base of the fifth metatarsal, you fall into a little groove, and that is where the cuboid is. So you can see that there's a generous amount of ligaments. Ligaments constrain movement. They allow movement, but they also constrain movement. And the foot, being as complex as it is, has multiple ligaments. And if we go back and look at the previous picture, you also see retinacula. And the retinacula are these bands of dense connective tissue that hold tendons against bone. It strengthens them by keeping them in place. So they're somewhat like ligaments, okay? They're thick bands that hold the tendons down and help it function as like a pulley, for example. Now here is a lateral view of the foot. So here is the calcaneus. Very, very large structure. And here is the cuboid. So you can see that the calcaneus has a powerful influence on that cuboid. Now, I'll put these anatomy pictures away. And I was blessed to have a human skeleton that I gave away. And it had one foot only, and it was a marvelous structure because I could move it and evaluate how motion is coupled through all these structures. And then I bought several anatomical models. This is a really cheapy version. And here is a model that's a little bit more expensive. And somewhere I have a very expensive model. And I don't know where. Here it is. Here it is. Okay. This is quite the expensive Cadillac model. It's good and it's bad. Everything has a plus and a minus. And in this example, the ligaments, you can visualize all the ligaments and the fibularis tendons here, and the cuboid is here, but of course you can't really see the joint. Okay, so but there is a little bit of accessory motion, and that's really nice. And this is pretty close to the amount of motion available in a human foot. So that's one of the advantages. I dropped a bone. Let me find it. Thank you. Now, when you have a client that comes to you and they have an acute cuboid syndrome and you manipulate it and they're happy, within 1, 2, or 3 visits everything is fine, that's great, and I've seen those. However, I have seen other cases in which there is a much more complex presentation in which there are several joint restrictions, not just of the cuboid, though this is where they tend to hurt the most. And that's what I have described as type 2 cuboid syndrome. And you can find that on the website. You can read that article. It would also be appropriate to call it a supinatory, a treatable supinatory pattern of that foot and ankle. And basically what you find is, yes, the cuboid is prominent and it is restricted when you clasp it and try to mobilize it up and down. The calcaneus takes on a varus or inverted position, and everything follows. Their fibula is typically anterior and inferior. The talus is typically stuck anterior, so when you try and dorsiflex them passively, you'll only get to neutral or perhaps 5 degrees, whereas on the other foot, they have excellent mobility. Now the talus, another fascinating structure, is a curved dome. Okay? Now the talus is designed to rotate, plantar flex and dorsiflex the foot on the ankle. Or when you're weight bearing, then it allows the lower leg to flex and extend on the planted foot. All right? You'll read in the literature some talk about anterior and posterior glide of the talus, but that is such a minimal motion that we need to focus much more on the main motion, which is that of basically plantar flexion, dorsiflexion. Okay? So what you find is that the talus is stuck, and because it's a dome structure, there's no pain. Person can still walk with their foot lacking optimal dorsiflexion, but because it's a dome structure, they're not aware of any pain. They might not be aware of any biomechanical dysfunction. Now, the treatment for the talus is, of course, to restore some posterior glide, but you have to hook the calcaneus and capture the talus with it, because the calcaneus is a lever to enhance the rotation, the dorsiflexion, the posterior rotation. So I like to do a posterior glide on the talus at the same time that I do a distraction on the calcaneus and a rotation. All right. So once we've restored that motion, then you check the tibia, the lower tibia, and make sure there isn't a forward fixation of the tibia. All right. So if there is, you mobilize the tibia posteriorly, and at that point you want to check rotation, passive rotation of the tibia. Usually it's restored. On a rare occasion it'll be restricted, so you stabilize calcaneus and you restore the rotation of the tibia. All right. You also want to restore superior glide of the fibula, posterior glide, and on a rare occasion the lateral malleoli will actually be stuck posteriorly. I suppose it's due to an anatomical variance, but whatever you find, you treat. And of course you check the top of it, which would be just below the knee. You check the superior fibulo-talar joint, treat it as needed. So then what you've done is you've kind of prepped the area. And there might be a little bit of a midfoot restriction that frees up quite easily. But now you come and you want to restore motion in the cuboid. And so you want to distract the midfoot, rotate the navicular, and bring the cuneiforms with it. And then what you do is you enhance inferior glide with pronation of the cuboid. And after that, if you retest all accessory motions, you'll find that they are all restored in these joints that we've been talking about, except that sometimes you still lack appropriate motion in the subtalar joint. Subtalar joint is a very complex joint. And the subtalar joint is designed for varus and valgus. So when you're looking at the back of a person's foot, you see the heel here. And it is designed to go into inversion, okay, and eversion, right? Okay. Well, guess what? A component motion of that is rotation, which is actually called abduction. So if the front of the calcaneus is going outward, that is called abduction. Okay? If the front of the calcaneus is going medially, then that is called adduction. The front of it is going towards the midline. Okay? So part of restoring the appropriate varus and valgus mobility of the calcaneus involves also addressing the rotational component of the calcaneus. Now, I'm speaking of a foot type that is different from the opposite foot and ankle on that person, and I'm speaking of one that is treatable. There are some people that are, this is quite common in the population, it really is. Treatable. There are some exceptions in which it's simply a developmental joint. They have a different joint on one side or both sides. They tend to have much more of a varus positioning, and it's not treatable. Try as you can, you're not able to restore those motions. So, but honestly, those are the exception, not the rule. If someone had a very traumatic injury and there was a bleed into the joint and they have dense connective tissue, you may not be able to restore those motions. But most of the times in a normative population, you can find that some motion is lost. And it certainly places the foot in more of an inversion, and we believe, reasonably so, that this encourages, it's a setup for an inversion injury. I believe that a lot of repeat ankle sprains are due to this treatable pattern that could be reduced. And in reducing it, you're going to balance some of the ligamentous tension, and you're going to reduce inhibition of muscle function, and the muscles are, of course, the secondary stabilizers. So balancing motion is certainly a worthwhile thing to do, and some of these motions, of course, the client has no control over them. So these are passive accessory motions. So that's my spin on cuboid syndrome. You have a simple type that responds beautifully, and then you have a more complex type that requires more work on the major articulations of the foot and ankle. And I like the analogy of the cuboid being described as a keystone. Now, it's the most lateral structure, so when it's whipped out there and stuck, and if you look at the plane of the facets, I think you'll agree that that's very, very possible for it to get stuck based on the tapering. You've just got to play with it. I can't really demonstrate this on this video, but very worthwhile to take a foot and ankle apart and stack the bones so that you can gain an appreciation for how these motions integrate. Was making a point. I was speaking about the cuboid being a keystone of an arch. Well, because it's the most lateral structure, in non-weight bearing that would make no sense. But as soon as you are weight bearing, then the rest of the arch, if you will, is the ground. Although it's flat, you know. But you get the concept. I think the concept of a keystone is that when it's seated, it makes everything strong. Everything is structurally sound. If previously it was stuck and you restore motion, most of the time there's not a true instability. Most of the time that restores normative function. But of course it would be described as a movable keystone. And I think the metaphor works. I think it helps explain the function thereof. And so I think we'll wrap this up right now. And I'm going to make a plea that with a cuboid syndrome in which it is not readily corrected, of course, you could have more complexity. You could have some ligamentous damage. You could have some tendonitis, etc. You would always have to check the anterior talofibular and the fibulocalcaneal ligament to look for, the typical kinds of ankle injuries and ankle hypermobilities. But for what seems to be a pure cuboid syndrome that's not responding to the traditional manipulation, I would suggest that there is a different and opposite mobilization to restore that motion, and that there is also a more complex pattern in which you need to restore all of the motion throughout the foot and ankle. That's an article that needs to be written sometime soon. If somebody wants to help me write it, I'm game. We'll conclude here. Thank you very much.